and this mess. Does it make difference, as I said before? Yes, of course. Imagine you want to treat this. All doctors that I talk to worldwide, they start working like this to the left. And this is a big mistake. The more you work in this way, the more you reduce volume in the face. Because the skin goes inside, it doesn't go out. So if you want to approach this, you have to contract this directly. It is not helpful to work all the cheeks in order to lift in this way. So first thing. Because what happens when you pass by this area with stronger parameters? That you remove those fat compartments that are really precious, that should not be removed, because those fat compartments are the ones that you lose during the aging process. So you have to keep them. So every time you approach a face, mark all the areas that you should not treat. First of all, we remove and we treat only what is necessary. Next one, please. We have three different actions. Lipolysis, or let's say ablation. This is the surgical step. The tissue that you remove is removed permanently. This is very important because you have to think that the patient you're treating, she will carry this result along life. So if you remove some fat compartments like this one that is so precious for the tightening of the cheeks, if you remove it, you will fasten the aging process. If you remove this one, you will fasten the periorbital aging process. So actually, it's very important that when it comes to lipolysis, you approach only those areas that are crucial for facial contouring. That means that you take a face and you mark what you want to remove, and you go with the fiber only with lipolytic parameters, only in the areas where you want to remove. To make it easier to be understood, think of Endolift as a negative filler. So with fillers, you inject where you want to project, when you want to switch on lights. With Endolift, you switch off lights. So they're really complementary. So think of the lipolysis, of the facial liposculpture as a negative filler. So does it make sense to reduce volume here? No, it makes sense to reduce volume all around the angle of the mandible. You just remove a little bit of fat here. You just remove a little bit of fat here, and your face will look lifted, even if you are not lifted. But the sculpting, the contouring effect will provide a lifted appearance. What do you do with fillers? You sculpt the angle of the mandible, and the jawline looks lifted. Here is the same. Just remove what you don't need. And this is meant to be the first step of a facial approach. First we do contouring, we work on fat. Second step will be contraction. What does it mean? What are we contracting? The skin? No, we said before that we are not shortening the skin. We are contracting the subcutaneous three-dimensional retaining network. What does it mean? It means that the septums, the retinacular cutis, will shorten and attract the skin on the mess. It is very important that how we move the fiber and the septins will be able to contract the septums but not to cut the septums. Because if we cut under the skin, we increase the laxity. That's why it's very important that when you work with ablative parameters, you don't lace everywhere, because you cut everything. You lace only where you need, and then you switch into quartating parameters in order to contract. Does it make sense?
Yes.
I did many mistakes in the beginning because, especially in those very lax patients, with severe laxity, I was thinking, I need a stronger treatment. I need more energy because I have to contract more. And that was a big mistake. When you have a severe laxity, you have suffering tissues. You have weak tissues. If the power that you deliver is strong, the tissues are not able to accept it. And you just kill everything. So one thing that I understood is that when you have weak tissues, poor tissues, lax tissues, you have to be very mild. Apply low energy for a much longer time. Because you need to support, you need to stimulate. This for me, my strategy in the beginning was just the opposite. The more severe was the situation, the more I was increasing parameters. I was looking maybe at 70 years old woman with severe laxity, and I was thinking, oh, I need at least 250 joules, or to 3,000 joules, 2,500 joules. And now I treat this patient with 800, 1,000. But slowly, you release it, you deliver very slowly. Do you agree with this? Did you do the same mistake? No, one session. It is meant to be one shot procedure, one session procedure. But during the procedure, you change. you make different things. Like with fillers. In the same session, you do bone sculpting with fillers, high G prime gel. Then you treat the subcutaneous layer with medium high G prime with cannula, maybe on the bone with needle, then which you switch into cannula, medium G prime for subcutaneous contouring, and then intradermal, very high tan delta, maybe needle again, very thin needle. So you adapt the tools and the gels to the single situation in one procedure. 3 steps: deep, medium, superficial. And here is the same: fat, contraction, skin. We have to think that this procedure needs to be planned differently from one person to another one, but I will give you some standardized protocols. So you just need to select, should I use this or that? But the protocols that I will provide you are fixed. I mean, this is what I'm doing today. And then stimulation. So the third part is going to be quality of the skin. I will present you the latest clinical study where we proved that we have new collagen production after injury and new elastin production. It means that we can regenerate the skin. So, liposculpting, subcutaneous contraction, skin quality. Of course, I have to use different parameters, different hand skills, and maybe different fibers. And I will show you why. Because I will show you who is using both fiber, linear and radial. Who is using only linear?
One session or you mean?
Only linear.
One session.
Who is,
The same session?
Now, if you do a treatment, do you prefer to use linear or radial? Who prefers linear? Raise your hands. Who prefers radial?
Actually, Doctor, we can't compare. Each has its application.
Sorry?
We can't compare what's preferable. Each has its application and each case needs.
You need a different fiber. Great. But sometimes you need different fibers in the same session.
And this is what
Unfortunately,
happens, actually.
unfortunately.
It's an extra cost,
But
but it's a must.
This is something that of course, I would prefer to use only one, but sometimes I'm forced to use two because they have much different behavior. The behavior of the fiber is so different that I will show you some features to make this clear. Next one, please. The system here doesn't like my computer. Next. Next. Okay. Now, go back. So this is an example of what I was saying before. Do you think the laser works on this screen? I don't see it. No, but it works, but it doesn't show this. You have to leave one. Okay, I'll do it myself. So, as I was saying before, to restore the jawline, when you have this jowling process, usually what I was trying to do in the beginning was just trying to lift the cheeks. Then I realized that it's much easier to remove the exceeding part of the cheeks that is exceeding the jawline, remove it, and you have faster, easier, and more effective effect. Then, once you remove this, you do contraction, and then skin quality. So 3 steps all the time. Next one. No, wait. What I was saying before is that some fat compartments should not be treated with lipolysis, as I said before, because another mistake which I did in the beginning, it was just that I was treating the whole face almost in the same way. And then I realized that actually it can't work. Like with fillers, that you map your action depending from the need or from how you want to sculpt and model each area of the face. Next one, please. Temperature. We know that we have different effects with different temperatures. And then I will show you also that we have a range of good temperatures or good energies that should not be exceeded. When I say that for collagen activation we need 42 degrees, what does it mean? It means that we need 6 degrees, because 36 we already have, that's body temperature. We need 6 degrees. 6 degrees is nothing. So I realized that is a number that I had in my mind for 10 years, but at one point I realized that I don't need 42 degrees, I need 6. I need to keep my skin, my tissues at 42 degrees for enough time to activate the issue protein and stimulate collagen type 1, 3 elastin production. But I also realized that all the times that I was trying to regenerate, to stimulate the skin, I was working with much higher temperature. And I will show you then the difference between the two fibers, and I will show you that it's impossible to rejuvenate the skin with a linear fiber. It's not difficult, it's impossible. For contraction, we need from 43 to 60 degrees. And for lipolysis, we need from 55 to 70. What does it mean, once again? It means that here we need maximum 25 degrees. It's nothing. So once you think about these numbers, you realize that most of the time you overtreat depression. Most of the time you overtreat. And if you overtreat, what happens? One more? One more? Not only that you have no results, but you damage the tissue. This is actually the key point. How can I be effective, or how can I be devastating in the tissue? So once again, think of that patient, 70 years old, severe laxity. Where do you have to work with this patient? Here and here, not here at all. When you have ablative parameters and you work on a suffering skin, you just kill everything. So just keep these principles in your mind for the, for the whole presentation. Next one, please. So we have different actions: thermal stimulation, coarctation, lipolysis, for different benefits: skin rejuvenation, collagen renewal, skin tightening, mild or moderate adiposity. And we have to select the action. Next one. Because we are targeting different temperature, 42, 55, 65. Next one. So this is, for me, these are, for me, the standardized settings that you can use all the time for each action. You want thermal stimulation, you use a radial fiber, 2.5, 25, 75. You can use that. Don't think. Use it. Try to use it, and you will see that it works. Coarctation, 3, 50, 50 radials, once again. Lipolysis, 3.5, 75, 75 radial, or even better, linear. So today, linear for me is the best for liposculpting, and radial for contraction and rejuvenation. Should I use both fiber all the time? No. If I have a thin patient and I don't need to do any liposculpture, I can use a radial. It's much better to use a radial. If I have a massive neck with a lot of fat, of course linear might help me to have a faster lipolysis. I can have lipolysis also with the radial, but it takes longer. So I can be faster and more precise with the linear, especially when it comes to this area where you can do the liposculpture, being safer on the nerve, because the energy is parallel to the layers and doesn't go deep as easy as you have in the radial funnel. So each time you have a doubt, use these protocols. 90% of time you'll be good. Of course, then customizing you can do it really better, but anytime, especially if some of you, I know you are all experts, so maybe some of you are trainers or key opinion leaders, so when you train someone, when you teach someone, offer these settings and say, work like this, and 90% of times, you do a very good job. Because this is what I do after 10 years, and after more than 2,000 procedures, I work like this. Next one. The question was, how many joules? This is a question that I'm always asked. How many joules for the cheeks? How many joules for the neck? How would you answer to this question? 200, 300, 400, or what I need? It can be so different from one patient to another one. But you know how doctors are, how we are. We need to have some parameters. More or less, I should do this or that, because it's in our mind, it's in our education. We need minimum and maximum, because now we know which is our road where we can go. Next one. I used to give this table. Don't take pictures. This is completely wrong. This is an old slide that I was using in the beginning, because at this point, all doctors point, yes, yes, taking pictures. Forget it, please, forget it. And next one. I would like to ask you, is it important only how much joules? Or should you ask me how I should deliver the joules? Just one click. If I tell you 10 joules, I can have it with 1 watt for 10 seconds, or I can have 10 joules with 10 watt for 1 second, which is the difference. So if I tell you 10 joules, I'm not telling you anything. Imagine you ask me, can you describe your friend, or can you describe, you say to a friend, oh, I went out last night, I met a very nice woman, and how was she? And I say, oh, she was 50 kilos. Does it make any sense? How you distribute these 50 kilos in the space makes a huge difference. So how you distribute 10 joules is the real problem that makes the difference. Because one click, this is the difference. If you have a well done meat or a grilled meat, which is best? It depends. I'm ablating tissue, I need to grill. Am I heating and stimulating tissues because I want a homogeneous coagulation, I want homogeneous heating? I need low temperature for longer time. Once again, 70 years old woman, sadness, poor skin, which is your side. We can't grill her, we can't. Otherwise, once again, we kill everything. Does it make sense up to now? Yes? Sure? Yeah. Everything clear? Great. Next one, please. This is the clinical study I told you before. What do we read here? This is the abstract, but first of all, significantly increased dermal thickness and enhanced the more aligned elastin fibers and increased type 3 collagen. Amazing. Elastin, collagen, and dermal architecture and thickness improved. But, where is it? Highlighting a known linear dose-response relationship. What does it mean? It means that it's not true, that the more I lace, the better it is. It's a curve. The more I increase the power, I increase the results. I reach my top, and then I go down. So there is not a linear response. It's a curve. We have to stay in the range of good energy. Next one. And here is the important data. At 6 months, 70% plus collagen with 5 joules per square centimeter. With 20 joules per square centimeter, 65. With 40, 60. The more you increase the energy, the less collagen you have. Elastin, the same. Dermal thickness, significant, marked, no change. No change. But I talked with the pathologist that did the study, and he said to me, at 40 joules per square centimeter, the skin was like a 90 years old woman. Next one. Collagen was fragmented and disorganized. So with 40 joules per square centimeter, we have a dramatic damage of the tissues. We have a significant theoretical or benefit range of energies going from 5 to 20 joules per square centimeter. Now you have your range, minimum and maximum. But this study has been performed on abdomen, so I'm expecting, when it comes to the face, that these values are lower because the skin is, the tissues are more fragile, thinner, and more sensitive, more reactive. So we should take, I think, 10 joules per square centimeter as our average level of energy that could give us the best result in terms of regeneration. Next one. So if I have to treat this area, that is more or less 15, 16 square centimeter, I have a range of 150 joules that I have to handle with, because I have to share it for lipolysis, for contraction, and for rejuvenation. It's not 150 plus, 150 plus. It's 150 in total. So you have to, divide, you have to split this amount of energy where you need. In some patients, they can use it more for rejuvenation. In some other patients, they can use more of it for liposculpting. Am I making things a little bit more clear?
Yeah.
Did you find some answers now? Next one. So more or less, when you approach an area, you must have an idea of how large is the area and which is the maximum amount of joules you can deliver. Because if you exceed, you have damage. So the thing is, while you are working, you must be able to see benefits immediately. Because if the numbers are growing, if the joules are increasing on the machine, and you don't see any change in the tissue, you are spoiling joules with no benefit, probably only with inflammation and damage. And that means that you have to stop immediately and think what you're doing wrong. Because each step, each shot that you give with the laser should provide an immediate result. If it comes to the lipolysis, volume reduction, immediate. Contraction, immediate. Pinching test should be positive. I think the battery is going. So while you are working, you keep an eye on the joules that are increasing, and this should correspond to clinical benefit. If there is not a correspondence, you have to stop. Next one. Next one. When it comes to settings, the problem is most of the time, and at least it was for me, that I didn't understand really which is the meaning of the on, the off, and what. I was just, okay, I just add a little bit of the on, add a little bit of what, but I didn't have the clear effect of what I was doing. So I started to ask me, which is the real sense of the on, which is the real sense of the off, and how can I optimize the on, the off, and what? Next, just one click. So I realized, because I decided to take pieces of skin, fat, muscle, I put everything on the table. During the blepharoplasty, to the skin, I took the fat, I took the muscle, and I started to play with numbers, and see what was changing in the effect. So I realized that T on is the parameter that is giving you the action. So T-on is what you are doing, what you want to do. Short T-on will provide stimulation, medium contraction, high lipolysis. Doesn't matter how many watts I have, the action, the clinical action. The clinical action is related to T-on. So this is what you want to do. T-off, one click. T-off is just your temperature control. What does it mean? It means that the longer is the T-off, the slower will be the increase of the temperature. Is it good or
Yes,
not?
yes, that's good.
It's good because I have more time for assessment. I can take more time. I can, I reach my target in a longer time, so I have time to read the clinical signs that the tissues are giving to me. Elasticity, redness, thickness, hardness. All these parameters should be checked during the treatment, and the longer is the T-off, the longer will be the time for assessment. But also, the longer will be the procedure. Because with T-on 30, maybe you have a 25 minutes procedure, T-on 60, 25 minutes becomes 50 minutes. So you double the time. But it's safety. And is time that you have to think, memorize, and learn. So I was fastening too much the procedures in the beginning. My temperature was out of control because I didn't have in my mind the idea that I should control the temperature, because controlling the temperature, I control the clinical action. Controlling the clinical action, I control the result. So this is your safety, this is your parachute. One click more, please. But what is the energy that you apply? Is the power that you put into the action that you already selected. I make you a very simple example now. Next slide, please. One click. We said T-on, heating parameters, T-off, cooling parameters, watt intensity. What does it mean? One click. Do you know what this is? A mixer tap. The one you have in your shower. First you select the temperature of the water, and then you decide how much water you want. But if you increase the watt, you're not changing the action. You are doing it stronger. You're doing it with more intensity. But the action is in T-on, T-off. So, you want mild temperature, but big shower when you are in the bathroom. So you increase watt, but you select T-on, T-off for 37 degrees, 38. Or you want very hot shower, but soft water, reduce watt, longer T-on, and you're going to have more temperature, but with a very mild flow. Is it more clear now? So don't be tempted. If you want to change your action, don't increase that, because you're doing the same thing, but stronger, and that the only thing that you increase is the danger. Next one. One more. So, these are the milliseconds. 0, 25, 50, 100, T-on, milliseconds. One click. Stimulation, skin stimulation starts from 25 milliseconds. When we increase, coarctation starts around 40 milliseconds. Next step is lipolysis, over 50 milliseconds. So in this way, it's very easy to understand that if I want to rejuvenate my patient, I have to work here. If I want to rejuvenate and contract, I have to work here. If I want to rejuvenate, contract, and lipolysis, I have to work here. But we said also that here we are of course stimulating, but the energy will provide a very high temperature that if you apply it for a longer time will damage the tissue. That's why it's very important that when you use long Thion, you do it for a short time only in selected areas, then you switch into coarctation for tissue remodeling, and then the last step, you work only on skin, but you are very conservative on subcutaneous septums, on fat. Now, I said in the beginning, don't treat this area, but now I can say, don't treat it with lipolytic parameters, but you can treat this area with a little bit of coarctation and tightening and stimulation. Now you understand better. Now I think it's more clear that each area should be treated and approached in different ways, and you must be aware of what you want to target and what you should not do in that area. Now, the question was before you asked me which settings. Now it's more clear here. Now it's easy because when you see a patient, you say, okay, I have a little bit of fat here, lipolysis, and I mark it. Here I need a little bit of, firming effect and contraction, then I know what to do. And then skin rejuvenation, and I know what to do. And I gave you standardized settings, 2.5, 25, 50 for skin, 3, 50, 50 for rotation, 3.5, 75, 75 for line. It's fixed. You don't need to double check. Double check, okay. Let's analyze it. What do you need in double check? Lipolysis first. Second, once you remove the fat, you have an empty step, you have to coarctate. So second step would be coarctation. Third step is stimulation. So I need 3 steps for double chin. And the sequence has to be this. First I remove what I want to remove, then I contract, then I rejuvenate. All the time. Yes, yes. And for fat you work deep and superficial. For coarctation you work medium. For skin, only superficial.
So you do 75, 50, 25.
For what? Lipo, 3.5, 75, 75. I gave you the parameters before. 3.5, 75, 75. My first choice would be linear fiber for liposculpting, radial fiber for coarctation and skin stimulation. That's if you want the best result. It's a matter of cost. I know. I agree with you. You double the cost. But you can share it with your patient and say, listen, unfortunately, for your situation, we have a mix of different complications, fat and laxity. If I remove too much fat in a patient that has laxity, probably I will have some difficulties in contracting. So, in this situation, I must optimize my action. So I will use the fiber that is the best for lipo and the fiber that will be the best for coarctation. And you say to the patient, I'm sorry, but if you agree, I can add 10% of the cost of the procedure, that more or less is the cost of the fiber, to give you 30% more of result. Do we agree with that? It's like when you approach a face with fillers. You don't treat all patients with 2 mil of fillers. Sometimes you need 1, sometimes you need 3, sometimes you need 6. It's not your fault. I mean, it's the patient that is bringing you a situation, and you have to approach it and say, how many vials, how many syringes for me? Or for you, 5. And for my friend, 2. It's not our problem. Different indication need different tools and different skills. So I always, when my patient call in the clinic and ask which is the price for Endolit, I always say it depends. I don't have a pricing that is the same for everybody. Some procedure, I do it in 20 minutes. In some other patient, I have to stay there for more than 1 hour. Can it be the same price? And sometimes I use 1 fiber, sometimes I use 2. So, dear colleagues, we are not magicians. We are scientists. We are doctors. we do what we can, and we have to provide to our patients the best we can. Not the impossible, but the best we can. So I can do the best in 2 fibers. I'm really sorry for this, but I will charge you only the cost of the second fiber instead of, I don't know how much is the average cost for the procedure, but let's say $1,500. Sorry if I talk dollars, but I don't know the rate. The conversion rate with your coin is difficult to do it automatically. $1,500. 2 fibers, $1,700. That's the cost of the second fiber. I don't say to the patient that is the cost of the second fiber, of course, but I will say, sorry, I have to up 10%.
Doctor, if the patient refuses, do you go for the treatment with 1 fiber? Or you just...
No, I say to her, I will be limited. I won't give you 100% of what I can do. I can give you 70% because you are limiting the possibility. Once you are fair with your patient, once you are transparent and you say, I need different tools in your situation to have a better result. If you don't accept, you might decide, okay, first, I won't treat you because or I give you the best or I won't do it. Or, okay, we will be limited. Which is the risk, she asked you. The risk is that if I work with a linear in the subcutaneous layer for a long time, removing fat, I will destroy the connections, I will destroy the retaining network. So I might have thinner neck, but with worse laxity. Can you accept that? And she says maybe, oh yes, I just want to look thinner. It doesn't bother me if I have a little bit of laxity. Okay. She is aware, she knows, she's informed, she accepted, you write the consent, of course, and you proceed with the proceedings. If she says, no, I don't want that, you can say, okay, you can use maybe a radial. I will have a little bit less lipolysis probably, but better contraction. Do you prefer this compromise compared to the others? And she said, oh yes, because I prefer to look younger than thinner. So always I note my patient priorities. Because sometimes fat is the priority for the patient. Sometimes he's just looking firmer with a nicer shape, not thinner. So I can adapt, I can set my treatment according to the patient priorities. Does it make sense?
Dr. Ricardo, first of all, I want to thank you. I'm on delay, of course, because of the flight delay. You're always welcome here, and it gives us pleasure to be among us. But there is one more question.
Yes.
Just let's summarize. It's like triads: stimulation, contraction, and
Electrolysis.
lipolysis. But when you said stimulation, it's for skin and subdermal tissue. You mean?
Yes.
Okay. And the contraction, for which layer?
Subcutaneous retaining network contraction.
The 5% and network.
Yes.
That's why I want to say it, because it's like 3D tightening.
Yes.
Among the skin itself, become the coil and the subdermal and the fiber septum network. It's like tent
Yes.
pillars,
Yes.
making contraction.
Perfect.
Yes, and that which is right in between, like stools, which is running between all.
Yes.
that.
Yes. So, just to make another example, imagine this room. Imagine the floor is this mass, the muscle, the fascia is mass. The roof is the skin, and we are in the fat, in the subcutaneous layer. In the subcutaneous layer, we have fat, we have septums, we have everything. It's a very complete and complex layer. So I enter with my fiber in this environment. And my target is destroying fat, because so I can lower the roof on the floor. I have some dangers. I have the marginal nerve that is running on the floor here. The nerve stays on the floor, doesn't stay. It's not floating in the middle. It's on the floor. I enter with the fiber. I know that the Mr. Nerve is there. I stay higher. I press right. I look at it, but I don't tweak it. I remove fat. Then the roof starts to lower because I'm removing fat. Then the septums, imagine we are the septum, become more lax because we shorten the distance. But if I keep working with a linear fiber, removing fat, I will meet these septums in very short areas, overeating, creating points of weakness or cutting, even worse. So how can I contract with a gun that is shooting precisely but very strongly? How can I contract? If I enter with my radial fiber and my energy flows in this direction, I meet the septums for the whole length with a very mild energy, and I just contract them. So remove fat, lower the floor, shorten the ligaments, and then stimulating the dermis for skin rejuvenation. My nerve is there. I know how to approach it with linear fiber or with radial with low parameters, so I don't risk to overeat the nerve. Where I don't have the nerve, I don't have this problem. I can work more relieved. But always imagine which is the environment where we are working.
Yeah, Dr. Ricardo, sorry also for interruption, but I want something to be clarified more. For the fiber in left, it's aligned and energy goes like in a straight way in the linear.
I have a very good slide for this. Next one. The fibers.
Yes.
Next. First of all, I want to ask you something. Next. Are you using ELX or FDF? Are you using these fibers? Or are you still using power cable and short fibers? Short. Believe me. Switch to these ones. You're using this one, okay, because here you have 20% more of efficacy and control, much better. Okay, if you use this, let's keep this. Next one. Next one. Next one. Okay, stop. Linear. In the beginning, I thought that the difference between one fiber, linear or radial, was just a matter of geometry. I have the energy here, or I have the energy here. But I was ignoring one thing. What does it change between, just one click more, please. Sorry, one more click. Which is the difference in the two emissions? The real difference from physics, which is the difference. If I have 3 watts here or here, which is the real difference that should make you think about. There is one parameter that we never consider, that is density of energy. If I have 3 watts in one point, or if I have 3 watts distributed on the table, here I make a hole, and here I just heat a little bit the surface. When you concentrate the energy. If you put all the energy in one single point, it hurts. But if I do the same energy in a large area, it's much milder. This is the difference. So with the linear fiber, you have all the energy on this tip. If I do the same thing, this sharp tip, I make a hole. But the same energy, I apply like this. It's completely different. That's the difference between radial and linear.
It's like sharp and blunt, yeah. It's more or less
Like sharp and blunt, of course. But even if it's so obvious, it took me 10 years to understand
Yes.
it.
I want to work with 2 fibers, okay? And given the license for the adoption and everything, and then I'm switching to the radial fiber. Do I distribute the amount of energy between both fibers, or I can give cooling time and then restart all over again?
This is a good question. The question is, we know that we have an amount of energy that we can apply. So does it make difference if we apply it all at once, or we give time to the tissue to cool down and then we heat again and we cool down and heat again? Yes, of course, you can increase in this way because by cooling you reduce the thermal damage. But what you have done on the tissue is done. So once you have done the lipolytic effect, once you remove the fat, that tissue has been already transformed. So if you overtreat, anyway you're going to spoil the structures because we know that we have a theoretical range. So your tissue are not able to accept and to stand with a too high amount of energy. So it's always better to respect our range, our safety or healthy range. If you need to exceed because you need to work more, then you can do what you said. Maybe you reduce the parameters, maybe you cool down the tissue, just wait a little bit, and you can proceed a little bit more. So of course you have a little bit of tolerance. But always remember that your benefit will be in that little cube of energy. So now I think it's more clear which is the difference between linear and radial. It's a huge difference. It's not only a matter of how large is the area where it works. One energy is focalized, very sharp, cutting, ablating energy. So of course I can have better coagulation and ablation. Radial, defocalized energy allows slower temperature rise. That means control. Control means safety, efficacy. Optimizing coarctation, also because of the geometry of the liver, because I can catch my subcutaneous septums in a longer area comparing to the linear, where I'm overeating some points. Next one. I'm going to give you something that is really, really fascinating. Linear fiber, we tested how the temperature growth in the tissue, measuring. After this setting is 2.5, 50. After 1 second, in front of the 2 millimeters in front of the linear fiber, we have 25 degrees plus. What does it mean? 36 plus 25?
51.
61. How can I work at 42 degrees for skin rejuvenation? If in 1 second, with this very low setting, after 1 second I have plus 25, after 2 seconds, plus 38, after 3 seconds, plus 40, after 4 seconds, plus 45. 45 plus 35 means 80 degrees. I'm carbonizing. So this is very good when it comes to fat, but there is another important thing in this slide. 2 millimeters apart, after 1 second, we have 0 temperature. After 2 seconds, 0. After 3 seconds, 1 degree. After 2 seconds, after 4 seconds, 2 degrees. What does it mean? It means that if you are trying to heat the dermis with a linear fiber, to have 6 degrees here you have more than 100. So you are stimulating the skin, but you are destroying the subcutaneous network. Remember in the beginning I said to you it's impossible to really rejuvenate the skin without damage with the linear fiber, because the cost you are paying is here. To have the correct stimulation laterally to the fiber. But this is telling us another very important thing. If my nerve is here, and I'm working here, I'm totally safe. Because laterally, before I have the energy or the temperature that can arm the nerve, I mean, I need to burn the skin, so the tissue. So the linear fiber, when it comes to working close to the nerves, any nerve, but especially for the marginalis nerve that comes very superficial here, this is a very important data because it's telling us I can be safe. I have to hit the nerve. I have to shut on the nerve to harm it. But if I just pass by, I'm very safe. One more. 3.5, 75, 75. Linear. Wow. Temperature is going very fast, very fast. But still, laterally, almost nothing. So now I think it's very clear what you are doing with linear fiber. You have an amazing, precise gun. You can shoot from 300 meters and catch your target, but you are hitting only one area. So all the rest will be untouched. Good or bad? It's not good or not bad. It's like that. And we have to manage with it. We have to deal with it. We have to think, what do I need? I need to remove some cicatricial supratip after surgical rhinoplasty. But I don't want to harm the skin. I don't want to harm the cartilage. So I will work with the linear fiber, very low setting, to remove the scar tissue and contract a little bit the septum, because I have a very narrow area here in the nose. This for answering, to your question before, what should I do on the nose? Radial. Completely different. I have nothing in front. Nothing. 2.5, 25, 50. But after 2 seconds, I have those fantastic 6 degrees where directly on the dermis for skin stimulation. And I have temperature along my septums. I can increase increasing my temperature, and I can contract. Because when I have 15, 20 degrees plus, I'm working at 50, 55, so over 50, over 43, we are coarctating, so amazing. I just need to adapt a little bit my parameters, 3, 50, 50, and I will start to coarctate, but no necrosis.
What do you think about creating a combination of like endoleft and another gene that can rise in this room? We want to spread all this energy. So the good thing is also endoleft, that is, as you mentioned already, either it's linear or radial, it's precise, and we can do in selected areas. But there's another machine that can spread the energy over a room, and you can make like the fine flash with endoleft, like.
Of course, you can do any combination. The good thing is that if you stay in that healthy range of energy that we saw before, from 5 to 20 joules per square centimeter, you know that you don't have any damage into the tissues. It means that after endolift, if well performed, you do a facelifting, and the surgeon won't find any fibrosis, will find a more elastic tissue, more plastic tissue. So you will improve the quality of the tissue, but you have to respect the healthy range of energy.
Doctor?
You.
Okay. I'm going to use one more fiber that is placed. I have focal sites, localized sites. All the diagrams are explaining the heat distribution while the fiber is parallel to the skin. What about inserting vertical, allowing the temperature to be?
The question is one step ahead. I mean, once I know how the fiber behaves, of course I can modify the way I apply it. Of course. Because I said to you, can we go back? One more, back? Okay. Now I am parallel to the tissues. I am parallel. But what if I insert the fiber facing the dermis? I can stimulate the dermis directly. I go in, then I bend my fiber, and I stimulate the dermis. But we have to be aware that you are stimulating with this amount of energy. So you have to be very fast, no overlapping, no multiple passes, just one pass, very fast, and then you can control a little bit the temperature. Or, as you said, as I showed for the perpendicular approach for the double chin, you can enter perpendicularly and work full thickness in the fat. That is very effective. But once you have your gun here, what do you have here? You have to be aware the area that you're approaching, because, for example, for the double chin is safe because you have 2 layers of fat, and the deep one is protecting you from damaging lymphatic system, muscles, and whatever. But if you do it just a little bit more laterally, if you just do it laterally to the medial platysma band, and you cross the platysma, that is very easy, you're going to have a lot of side effects.
Only if you have like good amount of fat.
Selected once again. I'm giving you a new perspective to deal with the tool. But once I tell you what the tool is doing, it's you are the pilot. You know how should I use it. So as she was saying, and as I said before, you have to plan your treatment. What do I need here? What do I need here? Another example, nasolabial fold. Many patients ask for this, and all doctors approach this area like this. No, if you want to remove fat here, just go inside, remove fat, that's it, and flatten. Because if you do this, you remove fat here, you remove fat here, and in the end, the nasolabial fold will be worse, because the more you have this empty area, the more the skin drops. So, I'm telling you how it works, but you are the one who has to decide how to apply it. And this is not something I can, give you, because each patient needs a different planning, like with fillers. More or less we do the same things with all patients, but no, it's not. Seems to be the same thing, but the amount we inject in the through ligaments, the amount we inject on bone or in subcutaneous, how we deal with G prime and elasticity, you do it automatically because you see the patient and you know that automatically you have to use one filler or another one. And here will be the same. You will see automatically the solution once you know what you are doing. And I hope this was the purpose of this meeting. Now, in the end, you won't have any doubt anymore. I need to do this, like you were saying, double chin. Okay, what do I have here? Do I have skin? Do I have fat? Do you need to contract? Once you know which are your targets, adapt the settings, and you know what to do. Very, very easy. You have to start thinking as a doctor. Diagnosis, and then therapeutic plan. Next one. Next. Next. No. Forward, not back. Okay. So, if this is the patient I want to treat, one more please.
Forward.
Okay. No, one back. Okay. This is where I use linear and radial. Linear to remove selectively the nasolabial factor hypertrophic nasolabial fat compartment. Here is where I want to delay my jowling and I want to cut it and reduce it, but contraction, cheeks and neck only radial. Because the job you can do for neck contraction with the radial is impossible with the linear. It's not hard, it's impossible.
So in the same patient, you can shifting between two fibers?
Linear and radial?
Yes.
Unfortunately, yes, because this double the cost.
Yeah.
But the efficacy is completely different.
So for the correction for the nasolabial fold, firstly you go with the linear.
Liposculpture.
Liposculpture. For the
Then
nasolabial
coarctation.
fat, then radial.
Coarctation. Because I can be safe on fat. So I can cross the precious fat compartment without destroying.
Can we see the previous slides with 575 radial?
Yes, can we go one slide back? One more? Previous slide. This one.
Yeah, because we only didn't catch that energy. So,
3.5, 75, 75. You see? Also with the radial you can be lipolytic because in 3 seconds, you reach 65 degrees. So you just need to stay there a little bit longer. But massive lipolysis, not so precise. It's good. If you have a big neck, you can approach it only with the radial. You just need to force a little bit on the energy. Or I will show you, in this case, I will show you how you can work with T of 0, continuous emission, that can be very effective for the double chin, but this is an advanced, I will show you on the practice.
Doctor, how can we relate this diagram with the speed of fibers?
This has been studied with 1 centimeter per second. Of course, if you fasten or slower, of course you change it, but we need some standardized parameters. But it's not really the pure number that matters. It's the behavior of the fiber that matters. Here, you can have lipolysis, but also be aware that if you do like superficial lipolysis with the radial, that can be effective, but you're going to have 60 degrees also on the dermis. That is not so beneficial. Okay? Is that okay?
I'm sorry. Also, we have a slide here.
No. I have to see because I took out these data from a complicated diagram with all the data, so I can sort out maybe also the 50-50. But as I said before, it's not the pure number that is important. Don't think that if you use this setting after 2 seconds, you can't bet that you have plus 20. It's the behavior and how you distribute the energy in the tissue that matters really, because now you really fully understand which is the real difference between linear and radial fiber. And you can select a compromise of the two. I do everything with the linear or I do everything with the radial. It's a compromise, acceptable compromise, but you have to approach the right patient for a compromise. Otherwise, I prefer, because if I work here or in this neck with no fat, if I work with the linear, I think I have one case here of total unsuccessful case. I have one, I will show you, with no result because I use the linear fiber with too high parameters. So, linear, precise gun for those fat compartments that I want to remove. Linear for the periorbital area, because here is very important that I choose, I select the layer where I want to work. Skin, muscle, septum, fat. I have 4 layers here, not 3. So even more complicated. And neck. Neck for me is only radial. If I have a patient that has the priority is the neck, for leg skin, only radial. Next one. I don't think we need to talk about the caliber of the fibers. What matters regarding the caliber? Sometimes the doctors say to me, it's better 300 or 400 for the neck. Does it really make difference? Which is the difference? Why do I need to increase the dimension, the size of the fiber? Imagine that the energy flows into the fiber like water in a tube. If I need to carry a lot of water, I will use a large tube. If I need to carry small water, a little amount of water, I can use a smaller tube. Otherwise, if I put a lot of water in the small tube, why do I increase the pressure? And then I risk to overstress the system. So if I'm approaching an abdomen and I am using 5 watts, 80-80, a lot of energy should be carried. I can do it with a 300 microfiber, but I have to change it every 600, 700 joules because I just cook it. I burn the fiber. I can do it. Another thing is that the bigger is the fiber, the more handy it is. So for the body, of course, a larger dimension helps in controlling the movement. But there is another thing. If I deliver 3 watts with a 300 micron or with a 400 micron, which is the difference? Density, once again. Oh, so you listen to me, huh? Great. Once you answer this question, it means that you did a good job today. I made it clear. Remember your pen. 300, 600. Imagine the same energy applied 2 different ways. Is it better or no? Depends what you want to do. The more I focalize, the sharper I am. Always. So if I use 300 or 400, to be able to have the same effect with the 400, I have to increase a little bit parameters because I am defocalizing. Next one, please. Next one. Next one. Go on, go on, go on, go on, go on. Numbness. I don't know if any of you started more than 5-6 years ago, but when I was trained to use Endolith without numbness. And I'm a good guy. I respect the rules. When they told me no numbness, I didn't apply any numbness. And all my training, I used to have quite good results in matter of skin rejuvenation, a little bit of coarctation, but poor results on fat. And patients were coming back to me after maybe 1.5 years, 2 years, and say, "Doctor, it was very good with Endolith, but now it's still, I see again a little bit." And I was like, "Oh, you've been happy, so shall we repeat it?" "No, thanks." No, it was a nightmare. Good result, but the procedure was too big. And if you look at the temperature, which I showed before, without numbness, you can accept 42 degrees. I mean, +6. Remember that 42 means 6. You can accept. You can accept maybe 10 or 15 plus. That means coarctation. But can you accept to work at 65 degrees with no numbness? No. The patient is going to kill you and bite you during the procedure. So I called the company and told them for the second, "Can I use it?" No, don't do it because you don't control the temperature. Water is just limiting the efficacy and it's dangerous. But I'm quite stubborn, so I started to inject numbness. So I was the one who introduced the Endolith X procedure, that means Endolith plus numbness, nothing else. And I started to work with numbness. And, of course, my patient was so happy. But it's only that. It's only comfort for the patient, for you. Or is there anything else behind the meaning of preparing the tissue with the numbness?
Dr. Ricardo, sorry, if you like to
Thank you that you spoiled my thought projecting everything. That was meant to be one step, but it's okay. Thank you. Yeah.
Dr. Ricardo, let me add just one point related to the anesthesia because I've used it like 5 years ago.
No, you can leave it. You can leave it now.
For the anesthesia, what I have is really successful. Just to introduce the anesthesia and the entering point. This is really what hurts the patient very much. When he goes all around underneath, it's not that much.
Not that much.
Yes, that's
But,
right.
yes, no, it's correct what you say. So they feel it in the entry point more than in the subcutaneous layer, of course, because the dermis is much more sensitive than the fat. But the problem is, do you remember the graph with the chromophore of 14, 17 nanometers laser? Water and fat. Water I'm more sensitive than fat. It means that all tissues that are rich in water are more sensitive, like dermis, for example. Fat contains only 15% of water, compared to the 80% of the dermis. So, of course, this reduces efficacy. So, a well-hydrated fat tissue, not tumescence, not overwet, but just hydrated, increase efficacy. And water is the perfect carrier for energy. It means that where you put water, the energy flows. So you can select the tissue and you can prepare the tissue by hydrating the layer you want to treat. But this is also important to keep in your mind, because if I do the numbness deep here, I'm just telling to the energy, go deep and go on the nerve. So the important thing is, we need to select the layer. So where we need to be superficial, numbness has to be superficial. Where we need to go deeper, numbness can go deeper, because this area is very safe. Where we put water, we have the energy, and a little bit of water helps. More water limits. So the less you inject, the better it is. I used to do the numbness with 20, 25, 30 cc for all face and neck. Now I'm doing with 10. 10 cc of solution. 2 of lidocaine plus 8. And you should be able to do all face and neck with 10, 12, let's say 15 cc. But 20, if you don't have a lot of fat, is already more than you need. So the reason to do the numbness are comfort, safety. Why? Because if you have, when you shoot with your laser, if you have a dry tissue, the energy stays there and you overheat that point. But when you eat the tissue with water, the energy flows. You distribute the energy in a larger area and you reduce the sharpness. You remember, sharp, deep is the same. Water makes the flow of the energy smoother. So, safer. And if you overeat in front of the tip of the fiber, you risk to carbonize the fiber. So the more hydrated is the tissue, the more you increase the reliability of the system, because you spoil less, you stress less the fiber. So you keep the fiber more effective during the treatment. One more. I don't want to bore you with how you should take the pictures, the photos. I don't think you have any doubt. Do you take pictures with your mobile? Usually? I do. Because now not always I have my professional camera. With mobiles, one thing is very important. Don't stay too close to the patient. Try to take a picture of your patient 50 centimeter or 1 meter, and you see two different faces. Have you tried?
So you don't like you said
Numbness, yes. No, because if you put
in case of
in case of lipolysis, body or face? Body or face?
I mean,
Of course, as I said before, if you have a lot of fat in the submental area, of course you need a little bit more solutions, but it's never a tumescence. So you should have, the tissue should remain soft. You shouldn't feel the hardness of when you do a tumescence. You should not increase too much the volume. You should hardly see the difference in matter of volume. So it has to be hydrated. Different when it comes to the body. If you want to do a lipolaser, that is not endolaser, it's another application. If you do lipolaser combined with suction perhaps, then you need a tumescence, so wet or hyper wet infiltration. But this is another thing. So when it comes to endolith, endolithics, you need hydration. When it comes to lipolasers, then you need electrolysis. Well, not hydrolysis. I will give you a table for this. Just one recommendation, because when I go to congresses, unfortunately I see a lot of colleagues with very good results, but horrible pictures. Once you have pictures that you can't compare because the angle is not the same, the background is not the same, the light is not the same, one is made indoor, the other one is made outdoor, different cameras. If you can't compare the pictures, even if you have the best results, unfortunately, they're not so effective, you know. Next one, please. The third foundation. I didn't introduce the three foundations, technique, laser, and fiber. We talked about the laser before, then we talked about the fiber, nut. The third foundation is you, the technique. How? We saw before what is doing the energy, then we saw how we apply it in the fibers, different behaviors of the fibers, now different behaviors of the operator. This is the last step. Entry points, I think we don't need to discuss this, but I just want to tell you one thing. Vertical vectors for contraction are more effective than horizontal. Full stop. Don't ask me why, I don't know, but believe me, when you work like this, you contract more than when you work like this. Next, 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 next. Okay, now let's go into clinics. We have to approach patients. Basically, we have two big groups. Those patients that during the aging process develop hollowness and laxity, and patients that during the aging process develop hypertrophic fat compartment with hypertrophic fat compartment, laxity, and tissue gliding, vertical gliding. Sinkers, they have the tissue glides medially, saggers vertically. Now I think it's quite clear that we have to approach them different ways because we need different actions. So in this case, we don't need to do any liposculpture. In that case, we need the three action full. So now it's very easy to understand that here, as we don't need fat debulking, it's less necessary to consider the linear as a good choice. But the linear might be useful combined with radial in saggers. Next one. So, sinkers will need two steps. Coarctation, 3-50-50, radial fiber, rejuvenation, 2.5-25-50. Use these parameters, please, try. Even if you are used to use different parameters, just for me, next week, use these parameters just once and try. In the same sequence that I'm telling you now. Lipo, coarctation, and skin rejuvenation. Next, so this patient, she's a sinker, laxity, contraction, 3-50-50, rejuvenation, 2.5-25-50, radial fiber, 300. Next. First, I start with contracting vectors. I will show you a short video, but we have a real case today, so we will discuss it. When I do these vectors, I do one line, not multiple passes. 1, 2, 3, 4. Stop. You should see the contraction immediately. If you don't see it, you are not applying the energy in the correct way, or the fiber is not working. Maybe it's dirty, maybe the machine is not set in the correct way, maybe you are too deep or too superficial. But one single pass should provide a changing. If it's not enough, you can do a second step, repeating the vectors, but don't overlap. Why? Don't overlap. We are working here. Why should not we overlap? Because if we overlap, we increase the temperature, we start to treat the fat. even if we have coordinating parameters, but if you overlap and you pack, you stack energy, the temperature will grow and you start to be life-related. That's why single step assessment, then second step, you have a very heavy, thick phase, maybe third step, but should be assessed. It's not standard. Some patients do just one pass, one time, single vectors, and that is enough. I use this, I will show you the patient. I do very slow movement. Imagine the family cuisine and then stop. So I have a little bit overlapping single shots, but I won't overlap vectors. You are running too fast. Let's go back. Second step, changing parameters, moving a little bit faster, skin stimulation. I know with these parameters that to reach 60-65 degrees, because the problem is that in sicker patient, we should not touch the fat, because we worsen the situation. We fasten the aging process. If in a sicker patient you remove fat, you just put the accelerator on the aging process. So we need to control temperature. So we know that with this setting, it takes a long time. I have to stay more than 4 or 5 seconds in one area. 5 seconds is a lot. 1, 2, 3, 4, 5 in the same point. It's crazy. So I can't control what I'm doing with this setting with the radial fiber. Remember the numbers with the radial fiber. Next, and this is the result. When I see this result, there is one thing that catches my attention. Quality. The quality of the skin has improved. And this is one of the most attracting things or intriguing things for me, because now I know that endolift is not only a lifting, and we also know that we are not lifting, but let's say it's not an endo lift, but it's an endo stimulation, it's an endo rejuvenation, regeneration. Also, not only lifting, but also regenerating. Why is this? Why is this important? I'm just, challenging you a little bit. Why is this important?
What's the question?
Hmm?
What's the exact question?
Why regeneration is so important? Because I might have cases where I can't contract because the patient is too lax, severe laxity, big fat compartments, and I'm really limited. If I have sagging muscles, I can't improve the situation because I can't control the muscles. But if this patient is coming to you with this severe condition, what can you say to the patient? I can't lift you, but I can rejuvenate you. This is an added value, and this opens, enlarges the indication of the treatment. Not only lifting, not only liposculpting, but rejuvenating. How many patients you have and you meet every day that would love to be only rejuvenated? So you have another limitation. For me today, I'm doing something different in this way. I can suggest to my patient, oh, doctor, I want to do biostimulation, I want to do vitamins, I want to do laser. We can't do laser to rejuvenate the skin. I do endolift. Only to rejuvenate. Of course, radial, skin parameters. You can dare to do it without numbness, because if you work with 2.5, 25, 50 with the radial, you can work. Maybe, as he was saying before, just a little puncture or a little cane in the entry point, and then you can work. It won't hurt more than a cannula for fillers. It won't hurt more. And you rejuvenate. Very fast. A few minutes. A few passes. Stimulate the skin. And then injectable biostimulator. Such an amazing procedure. You can combine it with exosomes, you can combine it. I use it, I combine it very often with castrate. Of course, you can do it same session, or I give you another trick is before sculpture. When you have a second patient, a patient that has lost weight with a huge amount of skin, and you want to contract, what are you missing? I'm missing connections. If I inject Sculptra and I create a network of collagen, doesn't matter which kind of collagen, but still collagen, and I heat it with Endolift, I contract it amazingly. I didn't know this, I didn't think this, but checking, reviewing our cases history in the clinic, my assistant, I have a very clever assistant, she's an observer, and she said to me, did you see that all the patients that did Sculptra on the arms with Endolift, they had better results than patients that haven't been pre-treated with polylactic acid? Now, for me, when I have laxity and poor connections, I pre-treat the patient with polylactic acid. I increase the retaining net, I increase the collagen network in the subcutaneous layer, and then I contract it. So I put my target inside, and then I contract it. Amazing. Or you can do it potentially. Or later on, as you like, depends on the situation, depends on the age of the patient, and so on. Next one. Saggers. We can refer to the Merz scale, severity of laxity, which is the best indication for Endolift. Class 1, class 2. Why? The answer is precise. Why class 1 and 2 are more indicated than class 3 and 4?
In case 3 and 4, they have laxity in the muscles as well.
This is the answer. Muscles. When muscles are involved in the aging process, we have a limit. Because remember that you can lower the floor, the roof of the floor, but you can't change the floor. If the floor is coming down, you can't change the floor. You can lower the roof on the floor. So of course, I can treat. I'm not saying that you can't treat. You can treat, but you have to be conscious that you have a limit. So, up to class 2, you can gain 2 classes. Class 2 can be class 0. 3 and 4, you can gain just 1 class. 4 can be 3, 3 can be 2. That's it. This is something I discuss with the patient. I show this picture to my patient and say, which class do you belong to? And she says, oh, I'm class 3. Okay, do you like class 2? Because I can carry you there. Oh no, doctor, I like class 1. No, I can't do it. What does it mean I can't do it? It means that if the patient class 4 doesn't accept class 3 as a result, you can't treat her. You can't. From a legal medical point, she's not accepting the treatment. And you can't treat. So this is very important. Then you say, okay, I won't treat you. And they always say, okay, no, it is enough. It is okay. I accept class 3. But here something is missing. What? This is only a matter of how much tissue I have. This is not taking into consideration the quality of the tissue that we saw before. Why I was challenging you with that case before, why quality is so relevant. Because a class 4 patient can be not, maybe you can't live, but you can rejuvenate. And this is an added value. So I show pictures to my patient of class 4 patients, and they see, oh, okay, you didn't live so much, but she looks younger. And that is all healthier, let's say. And that is even more relevant for that class of patients than being, lifted. Of course, I made some notes here. Class 1, pre-jaw, moderate submandibular. Class 2, pre-jaw and submandibular, mandible of the angle, angle of the mandible, nasolabial fold. Class 3 and 4, moderate debulking. If in class 3 and 4 you remove fat, you worsen the situation. I know it doesn't make sense, but better to have a nice remodeling of the face instead of achieving an empty face with even more severe laxity. So I'm very careful in approaching class 3 and 4 with massive lipolysis. I prefer, so my priority in that case is coarctation and skin stimulation. I do a little bit of fat debulking, but less than I would do in a class 2. Next. So for settlers, we have a 3-step procedure: fat, coarctation, skin. Do you need a break? Want a break? What do you think? Who that stuff? Huh? Oh, we finished with the video? Okay. I have more than 1 hour. No. But I can stop when you want, because this, we are around slide 70, 65, no. Please, no, go back. 65, so we have 150 slides, so we are in the middle. That is true. Okay, speed up. Okay. I'm too slow, she's saying I have to speed up. Is there anyone sleeping down there? Because I don't see everybody. Okay, 3-step procedure. Next. Class 2 patient, ideal patient. Next. Fat debulking. Where? 1 click. Here, for sure. Drawing a better jawline, removing what is not needed. 1 click, and nasolabial fold. No more for fat debulking. Do you agree? Yes. Because if we touch any other area, we spoil the situation. 1 more. No, wait. Settings 3.5, 75, 75. Next. Stacking mode for lipolysis. We will see it on the patient later. Next. Perpendicular approach for the submental area. Do everybody know this approach? No. For this particular fat compartment, you can approach it entering with the fiber perpendicularly and doing pillars of adhesion, like this. I have a short video to show. Next one. There are some areas that should ever be treated with the bulking mode. Angle of the mandible, malar area, preauricular area, lateral neck. Don't do lipo here. Do lipo here. The more you remove volume here, the more laxity you will obtain. Next one. Then contraction, vectors, single vectors. Next one. 3, 50, 50. And then 2.5, 25, 50. Stimulating everywhere, because skin can be treated everywhere. Next. Debulking mode, so lipolysis. Just 1 click. I reach my targeted area. I'm not lasing now, I'm just reaching the point. Now I'm lasing. Very slowly. But look, when I remove my hand, you see immediately the groove. Look how the tissue goes inside. Look. You see the dimple, you see the line of ablation. This is mandatory because this is a surgical step where you are cutting tissue. And every single cut should provide a reduction in volume. You see, I'm really selecting point by point. I'm not just lasing everywhere. I go with the fiber where I need, then I assess, then I remove. I'm like drilling into the tissue. And you see the immediate change. This is extremely relevant. Perpendicular technique. You pinch the superficial fat compartment, you reach with the fiber the tip of your fingers, and then you do pyramids of energy. In this way, you have point of adhesion, deep, full thickness. The skin goes inside immediately, and the pinch test will reduce 50-60% all at once. You usually do more or less 3 in the medial line, 2 before the platysma band, and 2, 3, 2, no more. You have a very high overeating here. Next, contraction vectors. One click. I reach the point. I'm not lazy. I'm just helping myself with some shots to proceed. Then contraction. I stop in one place and I make the tissue contract. Then I move. Then I move. I move. Peel, and also here I have points of contraction. I'm working in the medial layer of the subcutaneous layer, not too superficial, not too deep. Single lines, one click. I think you can see just one layer. Look at this cheek flat and look at this. Immediately reshaped. Immediately. You see the difference? This should occur immediately. If you don't see it, there's something wrong. Next. Third step, same question as before, rejuvenation. This is an old video. I'm using the linear now. I don't know if you noticed. I would do it with the radial now. That was a little bit, limiting my action. But anyway, I do faster, of course, because with the linear you need to control the temperature by fastening the movements. And this is the stimulation. Next. And this is what you should be able to achieve. Next. 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 Look at her 1 year after. Stable results. Next. Clinical endpoint. We all thought in the beginning that our endpoint should be numbers, 300 joules, 400 joules. Now we know that the endpoint is clinical, it's not mathematical, it's clinical. Joules. Why are important joules? Because now we know that we have a limited amount of joules per square centimeter that we can deliver. We can't exceed 20 joules per square centimeter, so it's very important that we observe the numbers, because if the numbers are increasing without improvement, it means that you're not doing the correct procedure. Volume should reduce immediately. If you don't see reduction of the pinch test, it means you are not removing fat. Skin elastic test has to be performed during the whole treatment, and you must be able to see the difference. Treated area, untreated area, you must see a difference. Same thing for contraction of the subcutaneous layer. Next. So, treated, untreated. Look at the pinch test on the neck here. I'm able to pinch the untreated area, but I can't even pull the skin on the treated part. And the thickness, before and after. Immediate 50, 60, 70% of thickness reduction. Next. Laxity. Thickness and amount of tissue I'm able to, one click, I'm able to pinch. But look also the firmness of the tissue. You see see the difference in firmness. How firm and elastic looks that side comparing to the no treated. And there, look how I can pull the skin on the side that I didn't treat. So these are the signs that you should be able to appreciate, to observe during the treatment. Next one. The tissues are giving you signs. You have to be able to read these signs. So the first thing you have to see, it doesn't matter which action you are performing, lipo or quartation, the first thing you have to appreciate is the result. If you see erythema, if you see redness, and you didn't see the result, stop. If you see hardening in the district without result, orange light, better to stop, because the next step is the pinch test increase instead of reducing. You already damaged the tissues. But you have 3 steps before the damage. So first of all, when you work, you have to see the changing in matter of volume, elasticity, and so on. If you don't see changing and you start to see side effects, it means that you are not going in the correct direction. Next one. Next. What a nice case, huh? Which is best, before or after? She was better before. What was the mistake here? She lost fat. And she lost connections. Why? Which was my mistake? Linear. And 3 50-50. If 3 50-50 is coarctation with the radial, but with the linear, remember, if I work with a sharp tip, I just cut everything. That was my mistake. It's not machine. So this is, I was so disappointed. I mean, she came back after 3 months, and when I saw this picture, and I prepared the picture because I'm always used to see very good results. So I prepared, I took the picture, and my sister prepared the photo on the screen of the computer. When I saw the picture, I said, no, we didn't take the good picture. So I said, we have to, and I treated her with the polylactic acid, and then I retreated the patient with radial fascia. Next.
You mentioned you shifted to the linear one nowadays. For the linear fiber, you already said that. You mentioned that you're using linear all over because you are maybe become more expert, so you are using linear all the time.
No. As I'm more expert, I prefer the radial. Experience is the name that we give to mistakes. That's the real thing. Yes, class 3, resulting class 2 in the end, lifted, good, better contouring, but quality. Once again, quality. I didn't, in the beginning, I was concerned only the shape of the face. But after a while, I realized that all patients that will show you, they have better quality. Next one.
Where did you use linear to that?
Can you go back to the
Go back?
Yeah, you use linear and radial.
Yes.
So linear would be
Yes. Fat. This, and here. See, it helps a lot when you remove fat all around the bone, just to create a little bit more shadow in this area. It's not relevant, but it's a detail that gives a nice reshaping of the jawline. Of course, now you can add fillers, you can add whatever you want, and even an even better result. Next one. Tightening and quality. 1 year after. She maintain the result perfectly. 100% of result after 1 year. Next. Next. Rejuvenation. You see? Quality. Quality is, I'm amazed because I was thinking once again of Endolift as a lifting procedure, is regenerating, is lifting through regeneration. Is more noble, you know, there is a more, the inner value of this is much higher than just lifting. Because this means that we don't have fibrosis, we don't have damage, we haven't damaged the tissue. Next. He looks younger. Doesn't matter if he still has a little bit of double chin. He looks younger. Yes, best. Younger. Once again. Next. Next. Look at her. 84 years old. I showed her the mass scale and I said, do you accept class 3? And she said, that little, but the improvement in the quality you can't show to the patient. So she has been lifted a little bit, but she has been mostly rejuvenated. Next one. I have hundreds of very impressive cases in my computer. Next. 1 year follow-up. Next. 2 year follow-up. Next. 3 year. Next. 5 years follow-up. So up to 4 or 5 years, you are able to see the benefit of this procedure. Next. Next. I don't think we need to talk about combination and synergies. I'm over more. Next. I don't think we need to talk about contraindication, exclusion. Next. Wait, no. Maybe just a couple of things about this. When you describe side effects of this treatment, bruising, hypersensitiveness, erythema, numbness, tingling, edema, subcutaneous hardening, these are not side effects. These are predictable sequelae. So, side effects is something that is not expected. Neuropraxia of the marginalis and seromas are side effects. But I show to my patient always a picture of a patient with the neuropraxia of the marginalis, and I tell her, can you accept this? It's extremely rare, but possible. If you don't accept, I can't treat you. It's not that you should not treat the patient. You can't. If she doesn't accept the side effects, you can't treat the patient from a legal medical point of view. Next.
Can you talk about the two slides?
Go back. Yeah, no. One next. This one. Yeah. I must say, the involvement of the marginalis branch of the facial nerve is possible, is rare, is temporary. It doesn't need any therapy. If you want to fasten the recover, so the first thing is don't eat any treatment. But if you want to fasten, you can use steroids, you can use hyaluronic acid, you can use vitamin B complexes, you can use bromelain, you can use many different things to fasten. But the thing is that the message you have to give to the patient is possible, temporary, no dangerous. That's it. If that happens, don't be so concerned in front of the patient. Say, okay, yes, we knew, don't worry, come back in 1 month, it will disappear. So once they understand that it's predictable and it's controlled, they don't worry. Of course they are annoyed, but they are not worried. Next. Always check the emission. This is an old fiber, don't look at the color of the fiber, but check. You see this spike? This is an incorrect behavior or emission of the fiber. Can this occur during the treatment? Yes. Every 50, 60 joules, you have to take out the fiber and clean it. Because if you don't clean and you test on your glove the emission, you will see spikes or not brightening light. That means that you are not performing 100%. So the fiber needs to be cleaned every 3, 4, 5 minutes. Next. 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 Go fast here. I was just to spend. Next. Okay, stop. I'm very happy to announce that we are almost ready with a very complete and, let's say, sophisticated protocol for the eyes. I'm not presenting this protocol today because we don't have, I say we because Gaia is taking part in this clinical study with me, and we are developing this protocol together. And but it's been a long way. We've been working for 1 year now on this protocol, trying to be sure that we can be safe and effective in a very sensitive area. Here we have to approach different indications, different layers. Next slide, please. Next. We have to be able to really select what we want to do regarding the layer, subcutaneous, submuscular. We have 2 different layers where we have to work. Which fiber and why we prefer the linear instead of the radial fiber. How we handle with the fiber, how we can select the tissue. And all the protocol is based, the next one, is based on a specific classification. Next. And the efficacy is based on real evidence of what we can do on muscle, on orbital septum, on ibex, because during surgery we have been observing the behavior of the 2 fibers and different settings in order to provide you the optimal settings for each area or each layer you want to approach. Next. So just to have a little discussion, even if I'm not giving you the full protocol, but just a little, we are just teasing a little bit the protocol. We will provide which are the best or the more comfortable and safe entry points, which are the vectors and the layers that you should perform, because once again, the layer where you work is relevant. Imagine, can we go back to one slide? One more? Okay. Can you just start the videos, please? Go back and then click again. Okay. The muscle is the tissue that we are not used to treat with endolift, because we said we can't do anything with muscles. But when you approach the eyelid, the muscle is there. And remember that endolift is a machine, or let's say Laserbar 1500 is a machine that has been created for endovascular treatment. So hemoglobin is a target, and the muscle contains much more hemoglobin than any other tissue. So the energy has a complete different effect on the muscle if we compare it with the septum. This is pure collagen. And look how the contraction is effective and no carbonization. The more I work on the muscle, the more coagulation and a little bit of carbonization I get, because I can't control so well the energy. That's why it took us such a long time to set the parameters and, but the most important thing is how you apply humidifier. So, when you want to work on eye bags, that is the big topic. Patient come with eye bags and say, I want to remove it, but I don't want surgery. How can I approach the fat? The fat is behind the orbital septum. Can I go with the fiber below the orbital septum? You can, but it's very dangerous, because if you have bleeding in the retroseptal area, you risk a retroorbital hematoma that has high risk of blindness. So we can't work directly on the fat. We have to work on the structure that is retaining the fat, that is the orbital septum. So it's mandatory that we are able to understand if we are working submuscular or not. But then to stimulate the skin, I have to work between the muscle and the skin. But if I do one layer and then I do the second layer, I treat it twice the muscle that is in between. It's getting, because here I remove the muscle because it's during the blepharoplasty. I remove the muscle. But if the muscle is there and I'm working on this layer, I am lasing on the laser. And then when I do the skin, I laze again on the muscle. The result is atrophy. So what took us a long time is the hand skillness that you must have to work on the eyelids. But I'm not telling you anything more, so now otherwise I have nothing to say. Next time we will present this. Next, so entry point, vectors and layers. Now, yes, one more. And the result. Quality, contraction, brow elevation. Amazing. Next, look at the lateral view. The elevation and the contraction is amazing. Next.
And you can repeat it also for better result later.
Quality. We succeed in contracting, not removing, but contracting the eye bags. Next. This is a case, amazing case from Gaia. And you see, flatten. Look at the retaining, look at the ligament. Contracted. You have to follow the ligament. You have to contract the ligament. The best result here is not only the eye bag, but is the orbital ligament that is stronger. Next. And here, skin quality, contraction.
But this is radial, right? Radial and also.
But if you want to know everything today, what I'm going to tell you next time. Linear. Next. Look at this case. This is a case of mine. She was concerned about this asymmetry. You see? I worked only on retaining structures. It was not a matter of rejuvenating. I didn't even treat the other side. It's one side treatment, just for retaining the action. Next.
Linear also.
Always. Next. We will also tell you how to avoid this. This is over-treatment, radial fiber. Next. For the periorbital area, I had this handpiece in my clinic in a drawer for 10 years. I completely ignored it. Then, once I was talking with Fabrizio Melfa, that is a very good doctor coming from Sicily, the south of Italy, and he told me, I'm doing this protocol for the eyes, next, where he is using the scanner, same laser, it's 1470. You know that we have this handpiece, maybe you have it, okay. You apply the scanner with 3 steps, rotating the scanner, one click. Each pass you rotate 30 degrees. Next. And you do 3 passes in the periorbital area. When he told me, I didn't trust him. And I tell you this thing because it's funny. So he told me this protocol. Then I went back home and I said, forget it. After a few weeks, he called me and he says, I'm sending you a patient for my protocol. I said, okay, I will do it. He's a colleague, he's a doctor. Oh, even worse. He's an ophthalmologist. I said, okay, hopeless. And it was my first time. So, well, let's go on. Next. Here you see the sequence of the treatment, and I will show you the patient. Next. Immediately after, next. 5 minutes, and next with the medication. Then he provides me some images with the dermatoscopy next, to see what happens. But next slide, next, no, one back. This is one of his results. And the next is the ophthalmologist that came to my clinic. Next, here is doctor ophthalmologist. And this is the result. My first treatment, I was so scared. You can imagine, ophthalmologist, first time to do a treatment. I was not even trusting the procedure, actually. But this was the result. Amazing. Amazing. He is sending me so many patients now. Yes, one treatment. Next. And also this case, very, very difficult. Thick skin. Thick skin. You're using Erwin? He said no.
Yeah.
Yeah, which one? Erwin Plus or New York?
I'm using everything.
Yeah.
Every meal.
Huh?
I'm using every meal.
Yes, but which is the post-op?
What is the post-op?
Yes, after treatment. What do you get?
Excellent results.
Hmm?
What do I get? Excellent. Good results.
Yes, but the day after, how do they look?
Of course, what I mean.
Huh?
Redness.
Redness and then bronzing. Here, nothing. Nothing. Just a little bit of redness that disappears in 24 hours. No cross, no bronzing, nothing. Nothing. You know the value of this? That kind of result with no downtime. You do it on Friday, on Saturday night you go out.
So let's, if you compare it to the linear, so this is
No,
like the.
this is outside.
Outside,
Yeah, but you can combine. In our protocol, we will provide also combinations in some degrees, because if you have wrinkles, this is more effective. Next. Shall we stop? Because I can go on, there was I just show you some very good cases from Gaia, from acne scars. I don't know if you have experience for acne scars. She's amazing. She has so brilliant results. Next. Just subdermal subcision. No, go back. I would like to show the video. One back and one forward. Yes. Maybe you want to explain it. No. Yeah. It's just a subdermal subcision and stimulation. Why linear here? Because we need to cut it. Then, once you do the subcision, maybe second step can be done with the radial, for rejuvenation, for regeneration. But the first step has to be with the linear, because we need to cut. And this is the same for cellulite body. You go with the linear, and you make subcision of the dimples. Next.
You're going fast.
Yes. And these are some results from her experience. She combines with exosomes. Not injection, not injectable, just topical exosomes. Next. Next. Okay. You asked me to show something about the lipolaser.
Yes.
Yes. So. sorry, this is a very long, just to make you laugh a little bit. This patient, I always commend this because it was great. She was great. She's a Chinese woman. She lives in Lugano, where I have my clinic. She's a very important, very rich family, Chinese family, very, very important person in the Chinese community in Lugano. She came to me and she said, I'm okay with my face. She was very severe. I'm okay with my face. I'm not concerned about wrinkles or anything. The only thing that really annoys me is that when I do photos, I look poor. I want to look rich. Endolift and light scan and exosomes. And a little bit of fillers in the tip of the nose. Yes, to help myself. She looks richer, yes. All the principles that I described today are the same for the body. Absolutely the same. This presentation needs a whole day, a whole full day to be described, but just scrolling all the cases, here it is. You know that for surgeons or for those of you that have a little bit of surgical practice, you can use this handpiece where you insert the fiber and you connect the vacuum machine and you can do suction and laser together. Extremely effective. One more. You know that the laser lipolysis has been, let's say, designed in the middle of the 90s because, of course, classical liposuction is limited when you have sadness. And with the laser, Havas Chamsadin demonstrate that you can have 50% more of contraction of the skin combining suction with laser. Next. So this is, I do this in my private clinic, so I mean, I'm doing it under local numbness, no sedation, the patient is awake, and I combine moderate suction with laser. And for tightening or for refinements or primary indication is amazing. So you see here how the light comes out from the cannula. You see the light here. So you perform laser and suction together, which is the benefit. First of all, the cannula enters the tissue very easily because the laser melts the fat. So you don't have so much resistance by the tissue. You extract. Can you reload the video? Then the fat that you extract is creamy, is an emulsion, and you see immediately the contraction. So very easy. You reduce a lot of bruising. In this case, like we were discussing, you do tumescence. Next, if you want, these are the published solutions that are codified. Tumescence, Klein solution, super wet, mega wet, epinephrine only. Those are different ways you can prepare tissues before laser-assisted liposuction. This is something you find in all the books that talks about these topics. Next. Next, please. And these are some results. Very good definition, very good contraction, remodeling. Next. Next. Camilla is a doctor that works with me. She's very good in body contouring. Next. Okay. I think I finished. Now, we started 2 hours ago, and I asked you which are your doubts and your concerns. Now I'm asking you again. Do you have any more doubts?
You have to try it.
You have to try, yes. But from theory, I mean, are the principles now more clear?
Much more.
Why linear? Why radial? How quartate? How lipolysis? Where and why lipolysis? Where and why quartation? I mean, I think, I hope at least that all the steps are more clear and more suitable for you. So how you optimize your tools in your hand and you know how to achieve the best or the better results from very we have 2 cases now. One phase and yes. Height? So okay, you can't put hypertension during all the treatment or only for the eyes. You should use it, yes, but I personally don't use it. I was discussing before with Guy, I have a problem. I'm colorblind. And I have some difficulties in seeing the red. So if I put the protection on glasses, I don't see the heavy. So I can't wear. To be honest, we don't need lipolysis here. We don't need contraction because the tissues are very base. Skin quality, yes, that's a good argument. Or acne scars can be treated, but most of the time, numbness here is a little bit more painful. If you treat a little bit more, sometimes you see a little bit of edema, dropping of the upper eyelid. It's a little bit a tricky area because the cannula, the fiber doesn't move easily. And all patients say, doctor, do the toxins here. So basically, I don't do so many. I know she likes to do it. And some tips and tricks. On the forehead. Yeah, that's good. Very strong extraction. This is what I said before. Once you know how your tool behaves, of course you can adapt it. I mean, I would show the patient, even if I didn't insert in the presentation, that I use 3 or 4 watts continuous for the neck to do lines of contraction, like you were saying for the face, and it's very effective. But these are, we go out from the concept of endolift. We use lipolaser adapting to the face, so we go out of the standards a little bit. But of course, regarding the forehead, the benefit that I always appreciate in patients is to treat the roof. Treating this area, the elevation of the brow is quite effective, and I experience, but as I don't have so much experience for the forehead, but my experience is that I don't see so much difference if I approach it like this, or if I approach it like this, treating only the roof. And approaching only the roof, for me, I feel it's safer because I don't have to cross the central branch. But anyway, as one of my mentors said to me, this is not a specialization where the technique matters, but only the results matter. That is true. So if you can get good results with the very personal, different technique, we just have to admire and observe and yes. Principles are the same. Of course, you need more larger fibers. You have a bigger tissue. You have to work with multiple layers. Of course. But the principles, once, I mean, the laser works like this. Doesn't matter if it is face, body, eyes, or whatever. The function, the properties of the laser are the same. So you just need to adapt and, and make different plans. There is a dedicated handpiece for that, and it's very effective. Not only for mucosal atrophy, but also for functional problems. You can do also stimulation outside, and it's very good for incontinence or whatever. It's very effective. I don't have a personal experience. I have a gynecologist in my clinic that is performing that, but they seem to put the patient from the first treatment. They say, I have, especially for pain, problem of pain, it's you have an immediate response. And the end is, I mean, it's not a consumable. You have it now. Okay, let's discuss the first case. Oh, yes, please.
For you first.
Coffee. Okay, coffee break. 10-15 minutes, and then we go on. 30 minutes. It depends if you want to stay here for dinner. More energy, and the more you work, the less result you have. I do 1,000. But I won't do it like this. So now you know, see the
Like,